Good afternoon, everyone, to those of you on the eastern side of the country, and good morning to those of you who are friends and colleagues out west. Welcome to the Systems for Action National Coordinating Center Research in Progress webinar series for today's talk on accreditation and multi-sector contributions to population health activities, a difference in difference analysis. I am Anna Goodman-Hoover. I am co-director of the Systems for Action National Coordinating Center, and it is my pleasure to be your moderator for this session, which is going to be featuring Dr. Rick Ingram. Dr. Richard Ingram is an assistant professor who, prior to joining the field of public health, worked in areas of fitness and wellness. He received his Doctor of Public Health from the University of Kentucky and also holds a Master of Education from the University of Virginia. Dr. Ingram's research interests focus on public health systems performance and structure, including the impact of variations in structure on health outcomes and practice-based research in public health. Dr. Ingram is going to be presenting on some research he has been doing intramurally with the Systems for Action research program, and we're very excited to hear from him today and to hear from our guest speaker, Jessica Kronstadt, in just a little bit. We'll begin with Dr. Ingram. Rick, take it away. Rick, I'm not sure if you're talking, but if you are, check that your line isn't on mute, please, because we can't.
Can you hear me now?
Right. There you are.
Great. Anna, thanks so much, and thanks everyone for attending the webinar. As Anna said, we'll talk a little today about kind of accreditation and how it impacts multi-sectoral contributions to population health activities. When we talk about multi-sector contributions, we're really talking about more than just who contributes to population health activities. While we do look at who's involved in the system, we also look at things like the strength of partnerships between the public health agency and other local public health system members. Things like how that effort to provide population health activities is distributed. The relative effort of the local public health agency, how much they contribute, and also how much the other kind of multi-sectoral partners contribute as well. So it's really not just who's involved. It really gives. It's more like it describes how they're involved as well. So it goes beyond just partnerships. So a little background about PHAB accreditation. Accreditation is a relatively new phenomenon in public health. It was launched a little over 5 years ago in 2011, so it's fairly new. It is voluntary, and this poses some problems when we look at kind of analyzing the impact of accreditation on various kind of outcomes, right? Particularly relative to self-selection. So, some postulate that agencies that choose to undergo accreditation are most likely already high-performing, right? They're already the ones that possess the high level of system capital necessary to undergo accreditation. They're the high performers. They probably already have a wide variety of partners. They probably also already focused to some degree on population-based preventive services. So this presents some difficulties when we're trying to examine how accreditation impacts these things, because these folks already are fairly high-performing, we think, which suggests the marginal benefit of accreditation may be much harder to to see, given that these agencies we postulate already are high performers. It might take a lot more effort to see any notable differences between before and after accreditation than agencies that probably offered fewer population-based services or involved fewer partners. And a couple things to remember. PHAB, views accreditation as a continuous process. Accreditation isn't just something you get. It's something you do. PHAB, their domain standards and measures are really rooted in continuous quality improvement. And they do have 12 domains, and these do reflect kind of current thinking on best practices. They're closely aligned with both the 10 essential services and the foundational capabilities of public health. And these domains were created, these standards and measures were created using input from a wide variety of groups with expertise in public health practice. They kind of represent kind of current thinking on what best administrative practice for public health agencies are. And it is important to note that PHAB accredits tribal public health agencies, state public health agencies, local agencies, and also territorial public health agencies. What we're looking at today is kind of the impact of accreditation on the local public health system. So we're looking at one of those, 4 groups. And PHAB accreditation does, as I said before, measure the public health agency against the nationally recognized set of standards, right? These are practice-focused and evidence-based. They are rooted into 3 core functions of public health: assessment, assurance, and policy development, as well as the 10 essential services of public health. I think we can all say the accreditation standards and measures are as evidence-based as they can be. Literature on best administrative practices in public health is pretty thin, and this suggests that these standards and measures are certainly evidence-based. But if you look at kind of the pyramid of evidence on the slide in front of you, they're probably on the lower the evidence that kind of that supports the standards and measures is probably lower on the pyramid, probably closer to the base than the top, right? Having said that, PHAB standards and measures, again, they aren't really controversial. They do reflect current thinking on what public health agencies should focus on. For example, PHAB requires a community health assessment as a prerequisite to accreditation. I think there's fairly wide agreement among the practice community that health assessment is a core part of public health practice. But nonetheless, the research we're going to talk about today really reflects an attempt to move the evidence base surrounding accreditation kind of forward towards a more empirical perspective, kind of moving from the bottom of the pyramid closer to the top of the pyramid. And I think this is important, right? Because PHAB accreditation comes with some substantial costs. The initial application fees for accreditation run along a sliding scale based upon population served by a public health agency. They run anywhere from $14,000 to $56,000 initially. That's a pretty good chunk of money, And then the annual fees to maintain accreditation, they follow a sliding scale as well, somewhere between $5,600 to $22,400 a year. So those are some significant just upfront and annual costs with accreditation. We also have to look at cost from the perspective of the public health agency employees engaged in accreditation activities. For example, while public health agencies are required to have an accreditation coordinator during their accreditation process, accreditation also requires input from multiple employees in multiple departments and programs to supply evidence that the agency meets PHAB standards and measures. I think that when you go through the accreditation process, given how comprehensive it is, you really are required to call upon just a large number of kind of employees in the agency to get all the information together to satisfy those accreditation standards and measures. Preparing for accreditation also takes a substantial amount of time. You've got to identify the documents necessary to kind of show that you are meeting the standards and measures. You've got to get those documents uploaded in the EFAB. You have to set up your site visit, things like that. So really, you've got a lot of time, people, and money involved in accreditation. Those all come with some fairly substantial costs. So the question kind of comes, it really begs the question: does PHAB accreditation make a difference? Right? Is it worth doing? I think a lot of evidence suggests that it is worth doing. Right? Accreditation necessitates engagement of partners from a broad array of sectors in the population health system. This is kind of the classic egg diagram most of you have seen that represents kind of what we feel the public health system in the United States looks like. If you assume that strong relationships between community partners makes a stronger public health system, then accreditation certainly may make a difference, right? Accreditation, for example, the accreditation prerequisites, the community health assessment and the community health improvement program plan, they require engagement with a wide array of community partners. Many of the standards and measures also require engagement with a wide array of community partners. So really, in order to attain accreditation, the big blue bubble, the big blue egg in the middle has to really kind of collaborate with and cooperate with a lot of the smaller eggs that are on the periphery of that diagram. So essentially, really, the activities related to preparing for and attaining accreditation, we feel have the potential to motivate the public health agency to reach out to a large number of these different eggs, that make up the public health system, and really kind of just create, just engage more partners in their activities. Again, another kind of key point here is that PHAB focuses on core population-based preventive services. They don't. So if you assume that public health agencies should focus on providing these core public health activities, accreditation certainly should make a difference. Again, it is singularly focused on population-based preventive services. PHAB does not accept nor do they review documents or programs related to personal health services. And really accreditation requires the public health agency to assess its capacity related to the delivery of population health services. So we feel that PHAB accreditation certainly could drive agencies to kind of emphasize these activities over maybe some other activities. So essentially, we feel that accreditation-related activities, given that they kind of focus on core population-based preventive services, they might have the potential to motivate public health agencies to focus on these core activities. Again, it is important to kind of, circle back and remember that the accreditation standards and measures do reflect current thought in best practices in public health. While they are rooted in the 3 core functions and the 10 essential services, PHAB standards and measures also adhere quite closely to the foundational public health capabilities recently developed. As you can see from this this table in front of us, or this figure in front of us, there's quite a bit of overlap in the realms of assessment, preparedness, communications, and policy development and partnership development, kind of those top 4 domains on the slide, right? There's substantial overlap between the PHAB standards and measures and these kind of domains. You can also see large amounts of overlap in leadership and governance, health equity, and accountability, including performance management and quality improvement. Again, if you look at PHAB standards and measures, this doesn't come as much of a surprise, right? Because those standards and measures, there is a large, there are a substantial amount of standards and measures that are focused on engaging, leadership and governance in public health agency activities. There are a substantial number of measures that are devoted to health equity, and assessing how agencies, what sort of strategies they use to achieve health equity. And obviously, given that PHAB is rooted in continuous quality improvement, it shouldn't come as any surprise that there are a number of standards and measures that kind of really dovetail nicely with the accountability, performance and management, and quality improvement domain. So it's clear that PHAB standards and measures reflect current thinking on the most effective ways public health agencies can deliver population-based preventive services. And we also feel that PHAB accreditation may provide a framework for public health system transformation. So we've conducted some previous research on the economic, political, and institutional factors that do drive system change. One of our key findings was that support from the local governing body, more often than not the local board of health, was a key determinant of local public health system change. Essentially, representatives that we interviewed from public health agencies that reported strong levels of engagement with their governing bodies told us that support from those governing bodies provided a critical framework they could use to help them change their public health system makeup. Essentially, they had that support to go and really reach out and try to affect greater change in their systems. They also reported that engaging with more members of the public health system, kind of these multi-sectoral partnerships we're talking about today, those were a key aspect of those efforts to change the system as well. Given that accreditation requires involvement of partners from a broad array of sectors, and also requires, the support of the health agency's governing body, it should come as no surprise that we feel that accreditation could provide a framework that might kind of facilitate public health systems seeking to change their system makeup. So it seems reasonable to suggest that accreditation might again lead to the development of stronger public health systems that involve, more partners and have more support from the governing bodies. So this kind of led us to postulate that PHAB accreditation may put in place an organizational framework that would lead to the development of what are known as comprehensive public health systems. Comprehensive public health systems, they offer a wide variety of core public health services. They also involve a wide array of partners from a multitude of sectors in the delivery of these services. In most comprehensive systems, the public health agency public health agency contribution to these activities is lower than those that aren't comprehensive. So really, it's a measure of kind of how many partners you're engaging, what you're offering, and also kind of how central the public health agency is to those activities. Right. And why is this important? Well, we know that comprehensive public health systems are associated with favorable health health and economic outcomes. Again, they are if you look at kind of our comprehensive system measures, they're closely aligned with nationally recognized standards, the core functions, the 10 essential services, the foundational capabilities of public health. We know that these comprehensive systems deliver higher quality services. They report higher overall levels of effectiveness than systems that are not comprehensive in makeup. Evidence suggests they can do this while requiring a lower per capita amounts of governmental resources. So they actually deliver higher quality services while spending, relatively speaking, less money to deliver those services. We know that movement towards a comprehensive system makeup leads to substantial gains in population health. Glenn Mays has an article coming out in Health Affairs, I think, next month that shows that public health systems that move from non-comprehensive to comprehensive system makeup, they experience greater reductions in mortality than those that do not move in that direction. So we see these kind of sharp reductions in preventable mortality. We also know that these reductions, that comprehensive system makeup, tend to disproportionately benefit poor communities. So we know that communities that have access to fewer resources, fewer economic resources, they experience greater reductions in mortality and spending than their more wealthy peers. So, as a poor community moves towards comprehensive public health system makeup, we see greater reductions in mortality and spending than their peers that are higher income communities that move in the same direction. So really it allows kind of those poor communities to do more with less. So the data we used for our study we're talking about today, we used data from what we call the National Longitudinal Survey of Public Health Systems. It's a cohort of over 360 public health systems containing 100,000 or more residents. So these are fairly large public health systems. And there are 5 waves of the survey: 1998, 2006, 2012, 2014, and 2016. The 2016 wave is currently in the field, so we'll get that data back fairly soon. It's important to note that the last 2 cohorts were supplemented with a nationally representative sample of systems under 100,000. And one of the phenomena we've seen in public health is that while most of our population is served by large systems, most public health agencies serve small populations. So this allowed us to get an idea of what these these systems represented by smaller agencies looked like. For our analysis, given that we were looking at change over time, we did not include this supplement of smaller systems in our analysis. The survey sent to the director of a local public health agency, and they or their designee report the availability of 20 activities associated with population-based preventive services, their effectiveness, how much effort the local public health agency contributes to these activities, kind of how central are they to the delivery of these population-based preventive service activities, and also what organizations from other sectors contribute to these activities. And one thing that's important to note is that this survey is we do use a validated survey tool for this. So this, while this is self-reported data, it has been shown to be valid. So it does gather data we consider to be valid data. So once we get the NLS-PHS data back, we use a kind of a combination of cluster and network analysis techniques to identify system capital, right? And then we use these techniques to classify communities into one of 7 categories of public health system capital, and they're based on really 3 basic measures. The scope of activities contributed to by each system member, essentially, what do these system members do of our 20 population-based preventive service-related activities we're looking at? How dense are the connections between these organizations that jointly engage in these activities? And then how central is the local public health agency to the delivery of these services? So we used a retrospective cohort design. Keep in mind that PHAB accreditation launched in 2011. So our first 2 waves of the survey, 1998, 2006, let us kind of look at what our systems looked like before accreditation. Our post-PHAB surveys are really our 2012 and 2014 waves. So we've got kind of 2 waves before accreditation was launched and 2 after, right? So that let us get 2 measures of what these systems looked like before they underwent accreditation, and 2 measures of what they look like after accreditation. So we divided our sample into 2 cohorts, systems containing accredited agencies, that was roughly 30 systems. And those containing unaccredited agencies, roughly 330 systems, right? We calculated the mean availability of core population health activities for both cohorts. We also calculated the mean percent of comprehensive systems in both cohorts. And then we calculated 95% confidence intervals for each measure, right? And again, just to keep in mind, this was restricted to our sample of larger departments. This slide shows the percent core population-based services offered by core function, assessment assurance, and policy development for both the accredited and the non-accredited groups during the 4 waves of the NLS-PHS. So the substantial differences, 5% or higher, are highlighted in yellow. You see the general trend here is that public health systems with accredited agencies offer a higher percent of services across all 4 waves of the survey. But these gaps do tend to grow particularly large over time for policy development and assurance. So while in all 3 domains, the accredited departments tend to perform better than their peers, in policy development assurance, the gaps between the peers tend to get substantially wider. You can also see we have substantial differences in 3 of the 4 waves for assessment and assurance, and substantial differences in all 4 waves for policy development. So again, this suggests that those accredited departments already possess, to some degree, higher levels of system capital as measured by the percent of public health services they offered. So this is kind of shows the aggregate measure of the percent of core population health activities offered by both groups. And again, this is a key measure of our development of comprehensive public health systems. You can see that the accredited cohort in the blue offers a higher percent core population health activities over the length of our survey, right? So that blue line is clearly above the red line from 1998 to 2014. You can see that over time the accredited cohort maintains and then slightly increases the percent activities offered over time. The non-accredited cohort displays kind of a slight increase from 1998 to 2006, and then it displays a reduction in percent activities offered from 2006 to 2014. So really we kind of see a drop-off in the non-accredited bodies and then a slight increase in the accredited bodies. For whatever reason, it's not on the slide, but we calculated confidence intervals for both cohorts, and the confidence intervals overlap until 2012, suggesting that there may not be any significant differences between both cohorts up to that point, but from 2012 on, the confidence intervals widen substantially. They don't overlap, so this suggests that there's a significant difference in percent core population health activities offered by the 2 groups in 2012, and in 2014 that trend continues to actually widen. And keep in mind that 2012 would be the first wave that we could detect any difference due to the accreditation activities. So what are our results? Well, obviously the accredited cohort offers a higher percent of core population health activities throughout the length of the survey. We see a decrease in the unaccredited agencies. We see a slight increase in the accredited agencies. And again, our confidence intervals overlap for both cohorts in the first 2 waves of the survey. They do not overlap in the second 2 waves of the survey, which suggests that significant differences do exist between those cohorts from 2012 on. This slide shows the percent core population-based services contributed to by public health members, public health system members from various sectors for both the accredited and non-accredited groups during our the first 4 waves of the NLS-PHS. Again, our substantial differences, 5% or higher, are highlighted in yellow. Kind of the general trend we see here is that at the beginning of the survey, local public health systems containing agencies that later obtain accreditation report similar levels of contribution to their peer system members. Report similar levels of contribution from these various kind of sectors to their peer systems containing agencies that did not receive accreditation. So we see very few kind of large differences in contribution between the accredited and unaccredited systems in 1998. But we do see a sharp rise in contributions from most system partners from 1998 to 2006, kind of across both across both cohorts. Then a decrease in contribution from other local agencies, state health agencies and other state agencies and federal agencies from 2006 onwards. So we kind of see a sharp rise in contributions for most partners from wave 1 to wave 2. Then we see a decrease in the last 2 waves, again, from other local agencies outside of the local public health agency, state health agencies, other state agencies, and then federal agencies. We see kind of, again, that similar rise between 1998 and 2006, but then relative stability in contribution from physicians, community health centers, hospitals, nonprofits, schools, faith-based organizations, and employers. So again, while we saw some decreases in kind of the governmental sector, we saw some relative stability in these non-governmental entities, right? Generally speaking, from 2006 on, though, we do see systems with agencies that attain accreditation report higher levels of contribution from a number of system partners than the unaccredited cohort. So generally speaking, the accredited cohort enjoys kind of their partners contribute more to these core population-based activities, with some exceptions, right? So in 2006, you can see the other category flips, right? So you've got a lower so accredited systems with accredited agencies seem to enjoy a lower contribution from partners in the other category than the unaccredited cohort, but then that flips again in 2014, so it's kind of a slight change there. In hospitals, 1998, you see that hospitals seem to contribute more to population health activities in the unaccredited cohort, but then that flips in 2006 and continues to widen in 2012 and 2014. So this shows you again kind of the percent of comprehensive public health systems in both our accredited and unaccredited cohort. Again, the accredited cohort is in the blue, the non-accredited cohort is in the red. As you can see, that the accredited cohort displays a higher percent of comprehensive public health systems over the length of our study, right? You see a similar increase in both groups from 1998 to 2006. So in both groups, they displayed a higher percent of systems that moved into a comprehensive public health makeup, public health system makeup. You saw kind of a similar decrease between 2006 and 2012. So both cohorts lost comprehensive public health systems. Then you see kind of a sharp divergence between 2012 and 2014. So our confidence intervals overlap until 2012, and this suggests there probably aren't significant differences between the two cohorts between 1998 and 2012. In 2012, they diverged, suggesting that significant differences do kind of start to occur. Again, 2012 is the first wave we could detect any difference due to accreditation activities. PHAB was first launched in 2011. This trend continues in 2014. So again, our confidence intervals continue to kind of widen. They get further and further apart. So again, the accredited cohort contains a higher percent of comprehensive systems throughout the wave of the survey. The unaccredited cohort experiences a decrease in the percent of comprehensive systems. We see a sharp increase in percent of comprehensive systems in the cohort containing accreditation agencies. Our confidence intervals overlap for the first 2 waves, suggesting there is no difference, and then they stop overlapping in 2012 and 14, suggesting significant differences do emerge after accreditation. So again, what can we conclude from this? Well, we conclude that systems containing accredited agencies differ significantly from their unaccredited peers, right? They display higher levels of overall system capital over the span of our survey, right? They tend to offer more services, and they'll also have higher levels of involvement from other sectors. So they really do more with greater involvement from more partners, right? And again, this suggests that there was this danger that the marginal benefit of PHAB accreditation could have been lower, right? Again, these were already higher performing before accreditation. They were already, you can see in both of our slides, the accredited cohort was always performing a little higher than their peers, right? But it was also suggested that it might have taken a lot more substantial change to make significant differences and we found significant benefits from accreditation or associated with accreditation in spite of this. And these differences manifested themselves after accreditation, which suggests that accreditation certainly may have had an impact on that. So as far as future directions, so and maybe Jessica Kronstadt will talk more about this later in our presentation, but so we are doing some work with the Public Health Accreditation Board. They've got what's called the Public Health National Center for Innovation, the PHNCI. It was funded by the Robert Wood Johnson Foundation to support innovative efforts to transform the delivery of population health services, right? These efforts are really focused on kind of reinforcing the delivery of foundational public health services and also health equity. I just thought that these might promote the development of comprehensive public health systems. So PHNCI has engaged with us to do statewide assessments of three members of their state learning community, right? It's Washington, Oregon, and Ohio. So we're actually currently fielding some pre-intervention surveys using our NLS PHS instrument. We're currently collecting data. It's in the field. I'm sorry. We just stopped collecting data. So we collected kind of our pre-data May through September 2016. We're going to do some post-data collection from roughly June to October 2017. That ideally will enable us to identify, kind of how these systems change over time. We can compare change between systems with people who are participants in the PHNCI activities and those that aren't. So it really will let us kind of get an idea of whether or not, or how the PHNCI activities are impacting how these public health systems, what they offer, and how they engage with their partners. Right? We also have, so during that period, we're also going to perform some qualitative interviews to explore the kind of more granular measures of system innovation and change. We're going to do, interviews with probably one location per PHNCI state. We're going to focus on really 5 areas. Kind of what sort of innovations did these systems in these? So what sort of innovations did systems in these states implement? Right. What sort of strategies did they use to kind of focus on the foundational services? What sort of strategies did they use to kind of move towards a more equitable public health system, population health system? How do these interventions or innovations align with the foundational public health services and the PHAB standards? What were the facilitators to success? What made things work? What sort of barriers existed that may have kind of hampered their efforts? And at the end of the day, we're looking at kind of outcomes. How did it impact health departments, health systems, and the communities they serve, right? Ideally, this will let us uncover strategies that these agencies can use to move towards more comprehensive makeup. So it'll let us kind of identify, what works. If public health systems are seeking to kind of move towards more comprehensive makeup, what particular strategies can they use to facilitate that movement, right? So ideally, it might result in a series of decision support tools that public health system members that are looking to develop more comprehensive public health systems can use to move their systems kind of in that comprehensive direction. Right. And again, this is kind of important. This is one of Robert Wood Johnson Foundation's culture of health. It's one of their 40 culture of health national metrics, right? And I think one of their goals is to have at least 47.2% of the population covered by, they'd like to have more than 47.2% of the population covered by a comprehensive public health system. Right? This is one of their metrics they're using to see whether or not they're going to attain those goals. And again, this also just kind of reinforces that, moving toward these systems does, I think in a good way, disproportionately benefit communities that are low-income communities. These communities often, experience great health disparities when compared to their peers that have higher incomes, right? You can see here that communities that kind of are lower-income communities tend to benefit both in terms of they see greater reductions in mortality and also greater decreases in spending than those that are more wealthy communities. So I think that's it, Anna.
Thanks so much, Rick. I see that some of you have already started typing your questions in the chat box. Please continue to do so. We'll be getting the questions in just a moment. But first I want to take this opportunity to introduce our guest commentator for today, Jessica Kronstadt from the Public Health Accreditation Board. Jessica is the Director of Research and Evaluation at PHAB, where she oversees efforts to evaluate the accreditation program and to promote research to build the evidence base around accreditation. Previously, she worked at NORC and at the University of Chicago, conducting research on public health services and systems, among other topics, and at the Public Health Foundation, focusing on workforce issues. Jessica received her Master of Public Policy from Georgetown University, and we are eager to hear her response to Dr. Ingram's presentation.
Great. Well, thank you, Anna, and thank you, Rick, for that thoughtful presentation. I just want to start by saying how excited I am to see research like this. From its very inception, PHAB has been very committed to research and evaluation, but it was very hard to do studies before you had accredited health departments or when we just had a handful. So it's really gratifying to see that we are now entering a phase where we have enough accredited health department that researchers are interested in conducting studies like this. On that one note, I do want to just put in a quick plug. If you are interested in helping to contribute to the evidence base, I would encourage you to go to the PHAB website. We do have information about the research questions that have been developed, our research agenda, as well as the availability of data. So if you are intrigued, please take a look at that, and the link will be posted in your ReadyTalk view. But I want to move thank you for allowing me to have that quick little infomercial, but I do want to respond to that presentation. And one of the things that I think will be helpful in providing context is to give you a little feel for where PHAB is at the moment. So as Rick mentioned, we launched in 2011. We accredited our first health departments in 2013. And I'm pleased to say that we now have 150 accredited health departments, as well as we've also accredited the local public health department system in the centralized state of Florida. And we have more than 170 that are in the system working their way through the process. So really a big change over the last several years. I will say our health departments are very diverse. They come from all parts of the country. I think we have more than 40 states have at least one accredited health department. They have different governing structures. And they're also different sizes. So we do have some very small accredited health departments, but I will say disproportionately our health departments tend to be on the larger size, which coincides with the population that we were discussing in this presentation. I will say a lot of what Rick said really resonates. There are many things that are built into the accreditation process that really should foster this idea of a comprehensive public health system. As Rick mentioned, the standards and measures are modeled around the essential public health services. So the idea is to cover a broad array of those core public health services. But one of the things that's very clear throughout the standards and measures is that in most cases, we're not saying the health department has to be the one that necessarily creates the policy or implements the program. There are many times where it's acceptable to use examples from partners or other organizations, but show the health department's role in it. We want to make sure that health departments are playing that assurance role, and that they're working with their partners to accomplish these goals. They don't need to be doing them on their own. In addition, we do have, as Rick mentioned, the Community Health Assessment and the Community Health Improvement Plan are very explicit mandates and requirements within the standards and measures to partner broadly. But we also have a whole other domain, Domain 4, about community engagement. One of the other things that is an important part of the process is when the site visitors visit the health department and they are interviewing health department staff, they also meet with both the governing entity and with community partners. So in one of the earlier slides, it was noted that having those strong relationships with partners, with governing entities, is an important part of the model of transforming public health. Those are both components of the accreditation model. And we have heard that those site visit meetings are really helpful to reinforce the role of the health department in their community and working with their governing entity. I will also say that what the findings here do resonate with some of the other evaluation findings we have heard. So we have a contract with NORC to do an evaluation of the accreditation program. It's largely focused on health departments' perceptions of what their benefits have been. And one of the quantitative findings in particular really speaks to this notion of working with others, in that more than 80% of health departments who've been accredited for 1 year think that the accreditation process has really improved their accountability to external stakeholders. So again, getting at that notion of working together as a community. from NORC's more qualitative findings, they've also heard from health departments who have said things like, and I quote, "We are more focused on the real needs of the community." Another quote saying that accreditation is one of the best leverage points to improve public health system and success on health measures. So we really are hearing from health departments from their perception about the benefits, particularly working with partners and others. So it is good to see those same findings reflected in this type of study. One of the things in the NORC evaluation that's been a really consistent finding is one of the most prominent and commonly reported benefits of accreditation is health departments strengthening their quality improvement and performance management work, and that's something that was really deliberately built into the standards and measures. What's interesting to me is that when I look at the annual reports that health departments are providing about what they've been doing since they've been accredited, we're beginning to see more of those health departments talk about using quality improvement not only within their own walls to improve, processes, administrative processes, that type of thing, but we're seeing health departments exploring using quality improvement with their community partners or working collaboratively on these population health objectives. So it is great to see something that was initially primarily of an internal focused improvement as a tool that can be used when working in a coordinated fashion with partners. The annual reports that we receive also really validate this notion about partnerships. I read all the time about the great work that health departments are doing to fight obesity by bringing in different sectors to come together and each playing their part. The phrase collective impact keeps coming up and up as I go through the annual reports is really something that health departments are beginning to focus on, the accredited health departments are beginning to focus on. And some of them have even said that to make the link even more explicit to accreditation, that some of them have taken on new steps specifically because of feedback they received in the site visit report. They were urged by the site visit reviewers to expand their partnerships, to maybe think more creatively about who they should bring into the fold. And so we really have had a couple of health departments who very explicitly said that when they received that nudge from PHAB, either in the site visit report or potentially in an action plan, that it really did allow them to expand their community partnership opportunities. So that said, as I said, there's a lot in that presentation that resonated. There were also a couple of questions that I was left with, ways where I would love to see additional research or additional analysis. One is, as Rick pointed out in the beginning, there is this concern about selection bias. So it would be great to see if there are other factors that might contribute to these different trends. So if, for example, let's say there are more of the largest health departments who are accredited, is there something about being a larger health department that would have caused you to be on a different trajectory over that time period anyway? So it would be great to try to control for those factors. I know in my mind, I think of, between 2006 and 2012, the biggest thing that happened in health is public health accreditation, but I imagine there are some that would argue that the Affordable Care Act also had an important impact over that time. So again, it would be good to make sure that some of these other factors about the health departments might not have interacted with the Affordable Care Act in a way that's different from the non-accredited health departments. And the other question that I would be really interested in exploring is what we could consider the exposure effect. So we know that health departments begin to feel some of the benefits of accreditation by going through the process, by doing a really honest self-assessment of where are our gaps against the standards and measures and working to fill them. So even before they're accredited, they may have discovered, oh, we really need to work on, if we're going to be able to meet the standards and measures, we really need to make sure that we have a strong community health improvement plan. So they might do that well before they're accredited. So one of the things that I would like to see in the future is perhaps taking a look, instead of just breaking the group into two cohorts, thinking about which health departments were in the system in 2012. And in 2014, which ones had started the process were officially in the accreditation system, and then compare those to which ones were accredited. So I think there are lots of different, there could be a more nuanced understanding of what the effects are of accreditation if you were to also look at which ones had formally started the process as well as which ones are accredited. So with those observations, we'll turn it back to you, Anne. I'm really curious to hear the conversation with everyone on the line.
Thanks so much, Jessica. And before we go to the questions that have been popping up in the chat box, I'd like to ask Rick if he'd like a moment to respond to anything you raise. And especially, I'm very interested in this idea of how we pull out confounders and start looking at potential confounders, look at what some of the mechanisms are for accreditation, promoting this multi-sectoral approach to population health, which is really a key component of RWJF's culture of health, as well as, of course, of the Systems for Action program. So, Rick, I'm wondering if you could talk about perhaps whether in the qualitative work or other work you have moving forward, how you're going to be thinking about teasing out some of those potential confounders.
I think Jessica raised some good points, Anna. I think in regards to kind of the Affordable Care Act, there is a lot of evidence that suggests that the Affordable Care Act certainly will impact how public health agencies and healthcare organizations, for example, work together, right? Individuals from those sectors. No question about that. I would suggest that everyone in our cohort was probably exposed to some degree equally to ACA-related activities. Having said that, if there were some states, for example, that expanded Medicaid, some systems and states that expanded Medicaid versus those that didn't, that could certainly confound our findings. Medicaid expansion might, for example, encourage public health agencies to work with other healthcare providers, kind of act as a bridge. And we've done some research looking at kind of how the ACA is impacting relationships between local public health agencies and state public health agencies and other healthcare system members. And it does suggest that there might be an opportunity, for example, for public health agencies to work closely with accountable care organizations and kind of act as a bridge between the ACO and perhaps some other provider as patients cycle in and out of insurance status, being covered, not covered. No question that's an impact, or that would have an impact. But again, I think we can assume that to some degree the ACA has impacted everyone, right? Another thing we didn't really talk about was kind of the impact of finance, right? We know that if you have more money, you're probably going to be able to spend it to do more things. So we saw this substantial decrease in health department funding, from 2006 to 2014. We obviously had the great quote-unquote recession, and that would certainly impact the ability of all these agencies to deliver services. These are, keep in mind, these are fairly large agencies. These are agencies that that enjoy access to fairly substantial resources relative to their small peers for the most part. But yeah, certainly there's the potential that, for example, some of these agencies that were accredited might have been able to be accredited because they just had more money to do more stuff with. No question about that. As far as kind of how to tease it out in the future, well, one of our big challenges here is that we only had a small number of agencies that were accredited over the time period we looked at. We've got the 2016 wave of the survey in the field. As we get a higher end of accredited agencies, we can do some more robust analysis that'll let us kind of look at whether or not, accreditation itself is the difference maker, if that makes sense. So again, as we kind of see more agencies get into the fold of accreditation, we'll be able to identify the impact of accreditation to kind of a more precise degree. But I do think that this is initial evidence that accreditation makes a difference. If you're looking at kind of just, fairly rapid cycle things, we've got some initial evidence that suggests it does make a difference. Because these agencies, while they were different over the course of our study, they were not significantly different in our measures until accreditation happened. So you have to kind of think that that might indicate that accreditation had at least some impact on it.
Thanks so much, Rick. As we transition over to audience questions, and we have a couple in line here, I would like to point out to folks, you saw this slide earlier. This is the slide for this project. So as findings continue rolling in, as products are developed and communication pieces roll out, including any articles about this work, please feel free to visit this website this web page on the Systems for Action website to keep up with the latest emerging from this project. And now I'm going to just switch gears and move over to some of our audience questions. Margaret Wright asked fairly early in the presentation if some agencies move from unaccredited to accredited cohorts, which might mean accreditation is pulling agencies into the model promoted by accreditation and leaving other groups behind. Which leads to another question. Is there a difference in makeup, demographics, description of the agencies that move into accredited and those that don't? And I think we've talked a little bit about some of those issues, but I was wondering if Rick and Jessica might respond a little more in depth on those two questions.
Yeah. So as far as the question of agencies transitioning from accredited or from non-accredited to accredited, we kind of separated our cohorts in 1998. So those that were in the cohort in 1998 were still in it 2000. In the accredited cohort in 1998, although they weren't accredited, we split them at that point. So they didn't transition from one bucket to another bucket. So we were very careful to split it early, right? As far as there being a difference in makeup or demographics or description of agencies that move into accredited and those that don't, again, I think it's important to note that there were no significant differences in our measures until accreditation happened. But nonetheless, there's a wide or a growing body of literature that suggests that accredited agencies are different than those that aren't. I know Goldar, Sean, Valerie Yeager published fairly recently some research that looks at kind of differences in accredited and non-accredited agencies. So we, for example, know that accredited agencies tended to have more of a commitment, for lack of a better way to phrase it, to quality improvement than those that didn't. That shouldn't come as any surprise, right? Because again, QI is a core part of accreditation. So yeah, those differences do exist. Sure they do. Keep in mind too, though, that our sample that we're looking at of accredited agencies isn't the entire body of accredited agencies. There were a lot of agencies that gained accreditation that were not in our that are not in our sample. Does that make sense?
Jessica, would you care to add anything?
As I said, I think this gets to my point that I think it will be interesting when you add in the 2016 cohort to actually start to look at that question of what time they entered the system and what time they were accredited to really begin to get an understanding of where those benefits begin to accrue, but that's obviously something we'll need a little bit more data before being able to explore more fully.
Thank you. Well, we have a question from Michael Dickey who would like to know what defines innovations implemented?
So that's a good question. I don't know if Jessica wants to kind of chime in here, but as far as innovations implemented, so for the PHNCI activities we're talking about, they are looking at kind of essentially, again, Jessica, correct me if I'm not representing this the right way, but PHNCI will engage with public health system members in these 3 states to create innovative strategies to engage more partners, to focus on providing core foundational public health services and also to focus on health equity. So I think those innovations we're talking about are going to be organically grown by those public health systems that are involved in the process. So it's kind of a moving target at this point, right? I think ideally after we look at Washington, Oregon, and Ohio, we'll have a more defined bucket of things to do that might be, worth trying in other areas, in other states. But right now, those innovations, all we know is they're going to focus on these 3 areas. I think that's fairly accurate. Jessica, do you have any thoughts on that?
Sure, and it's a great question. So actually one of the things that PHNCI is working on right now is trying to come up with a better definition of what innovation in public health looks like, and what, roadmap isn't quite the right word, but what are the characteristics of health departments that are innovative? But because I think there is a lot of ambiguity, that phrase is used differently. And so towards that end, PHNCI is going to be hosting a think tank very soon with leaders not only in public health, but leaders in innovation in different fields to really come up with a definition that will be able to, which will be published, which we will make available, and then we will be able to get feedback on those, from individuals, but also from the health departments that are current grantees, or if there are grantees in the future, to learn from their experiences. Because I think you're right, I don't think we have a clear enough definition of innovations in public health yet.
Thank you both. And now we're ready to move on to our last question of the hour, which is going to provide a wonderful segue to our closing portion of the call. And that is, Rick, how was the study funded?
Yeah, that's a critical oversight that I didn't put in the slide, right? So this study was funded primarily by the Robert Wood Johnson Foundation. They provided the funds we use to field the NLS-PHS and also do the analysis. I know that I'm fairly certain. I know Dr. Glenn Mason on the phone, and I know that in 1998, I think I think the CDC helped fund Glenn's initial data collection efforts, so I don't know if that would be, I guess they would be included as well. But I know that, right now our efforts are funded primarily by the Robert Wood Johnson Foundation through our Systems for Action kind of research mechanism. Right? And then obviously the PHNCI activities are funded. We are engaging with PHAB to do our research, but I know PHAB has been funded by the foundation to engage in the PHNCI activities as well. So there you have it.
Thanks, Rick. And I'd like to thank Rick Ingram and Jessica Kronstadt both for being with us this hour and sharing their work and thoughts on these important issues. This last question on funding allows me to remind folks that this is the Systems for Action Research and Progress webinar series. We have the Systems for Action National Coordinating Center here at the University of Kentucky, managing this national program of the Robert Wood Johnson Foundation. Rick is a member of the intramural research team, working hard to address a lot of questions about multisectorality, multisectoral alignment and collaboration toward promoting health and well-being across the U.S. We have more on deck from our intramural research team coming up in our very next Research in Progress webinar on October 26th, when we'll be hearing from the director of the National Coordinating Center, Dr. Glenn Mays, who will be talking about income and health inequalities and their relationship to population health delivery systems. Then coming up in November, we will be hearing from two of the collaborating research centers of the Systems for Action National Program. On November 9th, we'll be hearing from our Collaborating Research Center at Arizona State University. We'll be talking about financing and service delivery integration for mental illness and substance abuse. And then coming up on November 16th, we will be hearing from the University of Chicago investigators working on the Comprehensive Care, Community, and Culture program. We hope that you will be able to join us for these excellent presentations. All of these webinars do get archived on our website, Systems for Action and Public Health Services and Systems Research website. So please, by all means, check out the long history of recordings that we have there. Follow us on Twitter, and want to thank our staff for all of the hard work they do putting this webinar series together, in addition to our excellent speakers. And I'd like to especially call out Ann Kelly, who is a program manager here at the National Coordinating Center, who makes sure all the trains run on time. So thanks to all of you for joining us today. We hope to hear from you on our next call. Have a great day.